So next we'll see about endometriosis. So endometriosis is nothing but the presence of endometrial tissue but outside of the uterus. So the most common site of this presence of ectopic endometrial tissue will be in the ovary, and in the ovary it is called as a chocolate cyst. So with menses, every month with menses, this endometriotic focus is also going to menstruate. They are functionally active, so they are going to menstruate and this blood is going to be collected. So back to back every month this kind of hemorrhage is happening and the blood is going to accumulate in the ovary. So it is going to appear as if it is a chocolate cyst. So that is why this endometriotic cyst in ovary is called as a chocolate cyst. Other than that, you can also get endometriosis in other sites like pouch of Douglas, even in the broad ligament or umbilicus or any previous sites of surgery. Okay, so laparoscopic scar. So anywhere this endometriotic tissue can lodge and that can cause monthly menses in that region also. So what is the importance of this endometriosis is that it was going to cause abdominal pain and other AUB also, abdominal uterine bleeding. But the most important thing of which is it has a increased risk of transforming into endometrioid cancer, endometrioid carcinoma, or a clear cell carcinoma in the ovary. So in the ovary, if this endometriosis is there, it is going to be a precursor lesion for endometrioid adenocarcinoma and clear cell carcinoma of the ovary. So what is adenomyosis? So endometriosis and adenomyosis are going to be different. So adenomyosis is the presence of endometrial glands, endometrial tissue in the myometrium. Okay. If it was outside the uterus, it's going to be endometriosis. If it is present in the myometrium, it is going to be adenomyosis. Adeno means gland, meiosis means muscle. So this endometrial tissue could either be the endometrial glands or endometrial stroma. Okay. Next, we'll see about endometrial hyperplasia. So endometrial hyperplasia, so endometrial tissue is going to be sensitive to estrogen. So whenever there is going to be excessive estrogen production, so it will result in the hyperplasia of the endometrium. So this hyperplasia is again going to be a precursor lesion. So initially this hyperplasia can be a typical hyperplasia. So later on, if it acquires some mutations, the cells are going to become atypical, and this atypical hyperplasia is a precursor for endometrial carcinoma, that is carcinoma type 1. So some of the tumors which can produce increased estrogen is granulosa cell tumor. So granulosa cell tumor is a ovarian tumor which is a sex cord stromal tumor which is known for producing this estrogen. So this estrogen can stimulate a simultaneous endometrioid adenocarcinoma in the endometrium as well. So in the ovary there is going to be a granulosa cell tumor, and in the endometrium there is going to be a endometrioid adenocarcinoma. So endometrial carcinomas are going to be of two major types. So based on the pathogenesis and the mutations is going to be different. So endometrial carcinoma type 1, it is going to occur in both of it's going to be occur in postmenopausal age group only. So usually in type 1 it is going to be 55 to 65 years of age group, while type 2 is slightly in an elderly age group, 65 to 75 years of age group. And the precursor lesion for type 1 endometrioid carcinoma is going to be endometrial hyperplasia. So this endometrial hyperplasia I was telling, right? So this can progress on to type 1 endometrial carcinoma. While the type 2 endometrial carcinoma, the precursor is going to be endometrial atrophy. So while reading atrophy also, we mentioned atrophy is also, we all must suspect hyperplasia can lead to cancer. But here, even endometrial atrophy is related with cancer. So the best example is endometrial atrophy leading to type 2 kind of endometrial cancer. Then type 1 cancers are usually indolent, while type 2 cancers are usually aggressive. The mutations associated with type 1 cancers are PTEN mutations, ARID1A mutations, and microsatellite instability. So PTEN, do you remember? We saw it in Cowden syndrome. So Cowden, so den looks like 10, so P10. So this is going to be in chromosome 10 again. Okay, so PTEN mutation was associated with breast cancers and also thyroid cancers, then endometrioid type 1 cancers. Other than that, we had multiple hematomatous polyps. So you are going to have a PTEN mutation in type 1 cancers. Then apart from that, microsatellite instability. So what is that? There is going to be mismatch repair deficiency. So MMR genes which are MLH1, MSH2, MSH6, PMS1 and PMS2. These are going to be mutated. So we all saw it Lynch syndrome. Remember, this MMR deficiency is associated with Lynch syndrome, which is also called as HNPCC syndrome. So in colon cancer, we will be reading this. So this Lynch syndrome, we all read, it had a predilection for many cancers, especially colon cancer, endometrial cancer, and ovarian cancer. So the E for endometrium, so it is going to related to the type 1 endometrial cancers. So microscopically, type 1 endometrial cancers are going to have an endometrioid morphology. Okay, so the carcinoma itself is going to appear as if it's arising from the endometrial glands. So endometrial gland kind of morphology will be there, and it is called as endometrioid carcinoma. While type 2 cancers are usually aggressive and associated with aneuploidy and TP53 mutations. So anywhere TP53 mutations are there, it is going to be aggressive, right? So the microscopically, it is going to have either a serous carcinoma morphology or a clear cell carcinoma morphology. So in the endometrium, the endometrioid carcinoma is going to be type 1, while serous and clear cell carcinomas are going to be associated with type 2. Okay.